Hello, this is the week that we're going to talk about diagnoses and substance use in your Applied Couples Relational Therapy course at Antioch University. I'm Dr. Hayden Zeiger. Our objectives for this week are to describe the role of diagnosis in partners therapy, including systemic, relational, ethical, and contextual considerations. We're going to identify common diagnoses and clinical presentations that may emerge in partners therapy and their potential relational impacts. We're going to explain how major partner therapy models conceptualize diagnoses and substance use within the relational systems, or at least the major partner therapy models that we've been going over this semester. We're going to apply relational, systemic, culturally responsive, and ethically grounded approaches to substance use concerns in partners therapy. So just to be clear, we are going over two different topics this semester. So we're going over this week. So we're going over diagnoses in couples therapy, and we're going over substance use in couples therapy. So starting with diagnoses in partners therapy, diagnoses in partners therapy involves balancing individual clinical frameworks with systemic, relational, cultural, and contextual understandings of distress. Maybe I should use the word specific clinical frameworks there, since individual therapy is something different, right? So why and when to diagnose in partners therapy? Clinical and practical functions of diagnosis. So diagnosis may help therapists conceptualize patterns impacting their relationship, mood, trauma, neurodevelopmental, personality, substance use, anxiety-related concerns. Diagnosis can support treatment planning, case conceptualization, referrals, access to resources, and coordination of care. Insurance reimbursement often requires an individual mental health diagnosis, even when the primary concern is relational distress. When it comes to insurance, if you end up at an institution or clinic, or even in your own private practice, and you take insurance is going to require that you have a person who carries the diagnoses for the couple or partner group. And that person has to have a diagnosis that insurance will reimburse. And then that has to be like an ethically granted, clinically relevant diagnosis. You can't just slap a random diagnosis on there. It has to be a diagnosis they actually qualify for, and it has to in some way be impacted in something that you can treat with the therapy that you're using. Which, good news, research has been pretty clear that relational therapy shows improvements in a variety of mental health diagnoses. So that's not as difficult as it might feel. And then diagnosis may influence how partners understand themselves, each other, and the relationship. I also want to take a quick moment here. I've had students in the past talk about how CFT is like this non-pathologizing model. And I want to be careful that we're not confusing non-diagnosing for non-pathologizing. So while I certainly think that a lot of CFTers and LMFTers have a goal of being non-pathologizing, or at least I hope. I personally hope so. I hope that's where our field is leaning. I certainly don't see our history in that light. And I think it depends on how we view what pathology is and what pathologizing is. When we talk about low differentiation, to me, that is pathologizing. When we talk about triangulation, to me, that is pathologizing language. When we talk about avoidance, when we talk about emotional cutoff, when we talk about enmeshment, all of that is pathologizing language. It's just not the type of pathologizing language that made it into the DSM, right? But that doesn't change that it's still pathology language. So I want us to be really careful that we're not over-romanticizing our field, and that we're certainly not over-romanticizing the past of our field, the foundation of our field. Our field started off focusing on schizophrenia in the family. And concepts like this, schizophrenic mother is definitely a pathologizing term. So I just I just want to be certain that we are being realistic about our field and where we come from. And I also, on the other side of it, I want to talk for just a second about disability justice. So here at ANIAC, we are social justice minded program, and that also includes disability justice. And for better or worse, in the current system that we practice in and exist in here in the United States, access to resources are, if you don't have the money to fund that independently, is often based on a diagnosis. Something as simple as being able to access couples therapy or a partner's therapy is based on being able to access the diagnosis. So I want to also be careful that we don't demonize diagnoses for all that, like, there are some problems, to the point that we're reluctant to give ethical and accurate diagnoses when doing so means that our client can access resources that they need or that are helpful for them. So again, just a brief overview of clinical and practical functions of diagnoses. Risk and limitations of diagnoses in relational work. So continuing on with why and when to diagnose in partners therapy. A diagnosis can sometimes reduce shame through validation and psychoeducation, while also carrying risk of stigma over identification. So like we kind of have to balance this and where we're at. And how we're interacting with it as therapists, because that will often influence how our clients interact with it. Therapists should avoid reducing relational problems entirely to one partner's diagnosis or positioning one partner as the problem in the system. I think it's really important to be aware of the reality of needing to have a partner, a person who carries the diagnoses for the partner for insurance reasons, while not labeling that as the problem, right? So that's something that we just need to be careful about, that we're not blaming everything on that we are still being CFTs, we're still being systemic therapists, we're still treating the system, we're still treating the couple or the partner, and the partners, and we're treating that relationship, and not making everything about it being this one partner's fault. And then we also just need to recognize that symptoms don't occur in isolation. They're often shaped by relational, cultural, developmental, and systemic factors. Systemic and ethical considerations. Therapists often balance individual diagnostic frameworks and then systemic and contextual understandings of distress. So recognizing like what stress looks like in these frameworks. Diagnosis in partners therapy requires ongoing cultural humility, ethical reflection, attention to power dynamics. Again, we want to make sure we're not making this all about the partner who carries the diagnoses, that we are just focused on the couple and treating that, while also being attuned to, ethically attuned to what we're saying that we're doing for the diagnoses. Therapists often hold diagnoses lightly while remaining aware of our clinical, relational, and institutional impact. Therapists should only diagnose conditions for which clients meaningfully meet diagnostic criteria and avoid assigning diagnoses solely for administrative convenience, assumptions, or reimbursement needs. We should not be given a diagnosis that somebody doesn't meet criteria for, and we should not be giving a diagnosis that is not being adequately treated by the therapy that we're doing. So when I first see clients, something I normally check in on is what they've been diagnosed with in the past by care providers, or what they are currently diagnosed with by their current individual therapists. And then we kind of have a conversation about if that is something we're also trying to treat in couples therapy, or if there's something that's more clinically relevant when it comes to their diagnoses. So moving on to how partners therapy models see diagnoses, or at least the partners therapy models that we have been working with this semester. I'm going to start with emotionally focused therapy, EFT. EFT conceptualizes distress primarily through attachment needs, emotional regulation, and interactional cycles rather than diagnosis alone. Symptoms are understood within relational and attachment contexts. Therapists focus on patterns of emotional disconnection, vulnerability, and attachment injury. And diagnosis may help contextualize emotional experiences while avoiding reduction of distress to individual pathology. And then treatment emphasizes emotional safety, attachment responsiveness, and restructuring interactional cycles. The Gottman method focuses on relational functioning, communication patterns, emotional connection, and conflict processing. Diagnoses may help therapists understand stressors impacting the relational system. Therapists assess how symptoms influence communication, conflict, trust, intimacy, and emotional regulation. Emphasis is placed on observable interaction patterns and relational skill building. And treatment focuses on strengthening friendship, improving communication, and reducing destructive conflict patterns. The developmental model conceptualizes distress through growth, differentiation, flexibility, and relational maturity. Symptoms may emerge during periods of developmental stress or imbalance within the relationship. Therapists explore how partners balance autonomy, intimacy, and emotional responsibility. Diagnosis is understood within broader developmental and relational processes. Treatment emphasizes increased differentiation, flexibility, and emotional growth. Imago relationship therapy. So, imago therapy views symptoms and conflict through the lens of unmet needs, attachment wounds, and unconscious relational patterns. Diagnoses may help explain emotional sensitivities and reactive relational dynamics. Therapists explore how earlier relational experiences shape the present emotional responses. Distress is understood as occurring within relational interactions rather than solely within one individual. And treatment focuses on empathy, validation, emotional understanding, and conscious relational dialogue. Remember, the Imago dialogue. Object relations therapy conceptualizes symptoms through internalized relational experiences, attachment wounds, and unconscious emotional processes. Diagnosis is considered alongside relational templates, defenses, and emotional meaning making. Therapists explore how earlier relationships shape present emotional reactions and expectations, thinking about those objects that we're actually symbolically reacting to. Symptoms may reflect unresolved attachment injuries, shame, vulnerability, or internal conflict. And treatment focuses on insight, reflective capacity, emotional integration, and relational awareness. Integrative behavioral couple therapy, IBCT. IBCT conceptualizes distress through recurring relational patterns, emotional sensitivities, and behavioral interactions. Diagnosis may help contextualize emotional and behavioral vulnerabilities within the relationship system. Therapists balance acceptance-based interventions with behavior change strategies. Symptoms are explored within broader patterns of mutual influence and relational polarization. And treatment emphasizes emotional acceptance, communication, behavioral change, and contextual understanding within the couple system. If we're any of these that we lean towards, or any of these we're kind of struggling with, remember you can always go back and watch mine or Dr. Francis or Professor Pia's videos on the actual therapy models, or go back to your reading on those. And you're also welcome to reach out to any of us or your current professors about how to use these models. So moving towards thinking about common diagnoses in partners therapy. So what we're going over here are just some of the most common things that get diagnosed when it comes to partners therapy, and that are usually, at least as of right now, reimbursable through insurance, which is often when we do carry diagnoses. Now, even if we don't have a diagnosis on file, we should still have a reason for treatment on file, like a very clear statement about a reason for treatment. If you're not taking insurance, and so you don't have to put a diagnosis on file, that's fantastic. And you still want a clear statement about your reason for treatment there, because we are therapists and we're doing mental health care. We're doing, um, a healthcare service. For a healthcare service, there needs to be a reason for treatment. And I've definitely seen that be a problem for folks if they weren't taking insurance and they didn't have a clear reason for treatment on file. Because then there's not a clear statement of like what you're treating as a healthcare provider. So we're going to go over diagnoses. And I just want to make a very quick statement here that even if you're going to be, private practice, not take insurance, fantastic. And make sure on your files you've got a very clear reason for treatment. It may not have to look like a diagnosis. Diagnosis fits that criteria, right? But it may not have to look like a diagnosis for you, but there does need to be a clear reason for treatment. So we're going to start off with adjustment disorders. These are some of the more common ones that you're going to use. You need to be aware that these are only valid for about 6 months. Well, they are only valid for 6 months. After that, unless you can kind of prove that it's a different adjustment, you're going to need to diagnose them with something else because the adjustment disorder criteria is 6 months or less. So adjustment disorders, common relational patterns that we see are increased conflict, irritability, anxiety, or emotional withdrawal during stress or transition, relational strain connected to medical issues, financial stress, parenting changes, relocation, grief, or life transitions, difficulty adapting to changes in roles, routines, or expectations within the relationship, heightened emotional reactivity, or communication difficulties during stressful periods, right? So for just a second, I think it would have been maybe last semester, maybe this semester too. Last semester, I think you would have been taking assessment and something around psychopathology, maybe assessment and diagnosis around psychopathology. And this year, I think you were taking one last semester, and this semester you'd be taking two. If you want more information about these disorders, more in-depth information, please go back to your readings. Please go back to those lectures. But this is just like when we're applying this to our common relational patterns. And the therapeutic considerations with partners therapy with adjustment disorders is we want to explore both individual and systemic stressors contributing to distress. We want to support coping, flexibility, communication, and emotional regulation. We want to normalize stress responses while assessing for more persistent concerns. We want to help partners strengthen support, collaboration, and problem solving within the relationship. For generalized anxiety disorder, again, just some of the more common ones that we tend to put or that we tend to see with couples. When it comes to generalized anxiety disorder, or GAD, or often just called GAD, common relational patterns are reassurance seeking or conflict avoidance, right? Anxiety, emotional overwhelm or difficulty tolerating uncertainty, overfunctioning or underfunctioning dynamics, increased sensitivity to conflict, disconnection, or perceived rejection. Now, especially here with this like difficulty tolerating uncertainty, this is a symptomology in relational patterns that we see with a few different conditions, not just generalized anxiety disorder. So don't take any of these as like, I'm only going to see this with adjustment. I'm only going to see this with generalized anxiety disorder. We see this like difficulty tolerating uncertainty with like trauma conditions. We see this with like OCD and OCPD conditions, and just some other stuff as well. Therapeutic considerations support emotional regulation and communication, explore attachment and relational patterns surrounding anxiety, avoid positioning one partner as the problem, which we should be doing with everything. But it may feel kind of easier to do when you've got one partner who's especially anxious. Help partners differentiate support from accommodation or caretaking, right? So support is like more specific to what is going on, that we're going to just like help with this. Accommodation is when we're accommodating the person, but they're still the one that's like doing things. Caretaking is more of a like more intense role than either of those. So depressive disorders, common relational patterns. And again, like depressive disorders is category. So go back to your psychopathology course, look through those lectures, look through those notes, look through those readings. But when it comes to relational patterns, common relational patterns for depressive disorders include emotional withdrawal, low energy, hopelessness, or decreased engagement with the partner, increased conflict related to emotional availability, motivation, intimacy, or division of responsibilities, cycles of criticism, caretaking, guilt, resentment, or disconnection, reduced communication, pleasure, or relational responsiveness. And therapeutic considerations include exploring how depression interacts with relational patterns and emotional connection, avoiding framing depression as laziness, lack of effort, or lack of caring, support communication around needs, capacity, and emotional experiences, assess for suicidality, safety concerns, and need for additional support or referral, right? And that's the case with all of these, right? We always refer out if somebody needs more intensive care or needs care that is outside our scope or maybe outside the current scope of being a relational therapist. So even if I may treat this individually, I'm probably going to refer that out if I see somebody as part of a couple or partner. Trauma-related disorders slash PTSD, so common relational patterns for trauma, hypervigilance, emotional reactivity, avoidance, shutdown, or difficulty with trust and safety, conflict related to triggers, emotional regulation and intimacy, sexuality, or unpredictability, attachment injuries, fear responses, difficulty tolerating vulnerability, and cycles of pursuit, withdrawal, defensiveness, or emotional distancing. Therapeutic considerations are prioritizing emotional and physical safety within the therapeutic process. We may sit in like stage one or phase one or just that like joining stage of whatever therapy model we're using for quite a while. And that's okay. We're going to use trauma informed, non shaming, and regulation oriented approaches. We're going to help partners understand trauma responses within relational contexts. We're going to avoid pushing vulnerability or trauma processing before sufficient stabilization and safety. So, again, we may be sitting in the early stages of therapy for quite a bit with these couples, and that's fine. Just like that's fine with individual therapy, right? Sexual dysfunctions. So, common relational patterns include conflict, shame, avoidance, anxiety, or emotional disconnection surrounding sexuality and intimacy. Differences in desire, arousal, comfort, expectations, or sexual communication. Impacts on self esteem, vulnerability, emotional safety, or relational satisfaction. Cycles of pressure, withdrawal, rejection sensitivity, or avoidance. And again, go back to the sex therapy lecture, rewatch that if we want some more information about that. Go back to psychopathology, reread the material around sexual dysfunctions and diagnoses. This is definitely something that we can spend a little more time on understanding, because if you are working with couples and partnerships, you will interact with not just sexual dysfunctions, but like concepts of sex that are impacting their relationships. So therapeutic considerations are that we need to approach with non-judgment, cultural humility, and an awareness of scope of practice, right? If you're in Florida, you need to have additional training to diagnose this. So check your state, right? Some states it's not the case as long as you're in LMFT. Some states it is. Now, AMFT considers sex therapy, or at least last time I checked, AMFT considers like sex therapy as part of relational therapy. But not all states consider that to be the case. So definitely make sure you're working within your scope of practice and not diagnosing this if this isn't within your scope of practice. You need to explore relational, medical, developmental, and systemic factors influencing sexuality. We need to support communication, emotional safety, consent, and collaborative understanding. And we need to refer for specialized care when clinically appropriate. Remember our implicit model, and that, intensive treatment, we're going to refer out for intensive treatment when that's clinically appropriate. And the same here, like I treat trauma, I do EMDR for trauma therapy, including like sex therapy. But if I am working with a couple, I'm probably not going to take one of them on as an individual client. I'm going to refer that out to somebody else because we don't want to tip the alliance so that one person feels like I'm not as aligned with them as I am with the other person, right? Personality disorders and personality traits. So, common relational patterns with personality disorders and personality traits are intense emotional reactivity, instability, defensiveness, mistrust, or conflict escalation, fear of abandonment, shame sensitivity, emotional polarization, or difficulty with boundaries. Now, remember, like personality disorders are very different from one to another. So, we're way generalizing here. So, definitely make sure we go back and look at material. Cycles of idealization, devaluation, withdrawal, criticism, or emotional volatility, um, increased relational distress during periods of attachment activation or vulnerability. So, some of our therapeutic considerations are that we want to avoid stigmatizing or reducing clients to diagnostic labels, especially with personality disorders, because these are just so stigmatized. While still like maintaining safety and boundaries. We want to maintain clear boundaries, consistency, and emotional regulation within therapy. We want to explore attachment patterns, emotional meanings, and relational triggers. We want to balance validation, accountability, emotional safety, and systemic understanding, right? And we probably want to like do some additional training. So just like with sex therapy, we want to do some additional training with all of these, really. We want some additional training if we are working with personality disorders, we probably want some additional training just to make sure we're staying within scope of our practice, and that we are like doing what we need to for our clients. Bipolar disorders, common relational patterns with bipolar disorders, shifts in mood, energy, impulsivity, communication, sleep, sexuality, or relational engagement, conflict related to unpredictability, emotional intensity, spending, substance use, or trust concerns, cycles of caretaking, frustration, confusion, or emotional exhaustion within the relationship, and distress connected to depression or manic/hypomanic episodes. Our therapeutic considerations are to assess safety concerns, impulsivity, suicidality, and need for psychiatric collaboration, support communication and understanding surrounding mood related experiences, avoid oversimplifying relational concerns as caused by bipolar or caused by any of these. That's true for all of these, right? Help partners balance empathy, accountability, boundaries, and emotional support. Obsessive compulsive disorder, OCD. Some common relational patterns are reassurance seeking, rigidity, conflict around routines or uncertainty, or accommodation patterns within the relationship, increased stress related to compulsions, avoidance, contamination fears, uncertainty, intolerance, or intrusive thoughts, cycles of misunderstanding, frustration, or emotional distancing, shame or secrecy surrounding obsessive thoughts or compulsive behaviors. Therapeutic considerations are avoid reinforcing compulsions or excessive reassurance cycles, support communication and collaborative understanding of OCD related experiences, explore how accommodation patterns impact both partners and the relational system, and coordinate with specialized OCD treatment or exposure-based approaches when appropriate, and like referring out as appropriate. Autism and ADHD or neurodiversity, which really is not just autism and ADHD, right? Like OCD, bipolar, all of this is neurodiversity. But we're just going to talk about autism and ADHD here. So common relational patterns, differences in communication, sensory needs, emotional expression, attention, routines, or executive functioning, misinterpretation of intent, emotional reciprocity or responsiveness, cycles of overwhelm and shutdown, criticism or frustration, and shame or invalidation related to neurodivergent experiences. Therapeutic considerations are to avoid pathologizing neurodivergence or framing neurotypical communication as inherently correct, where neurodivergent communication is not correct. Support collaborative communication, accommodation, and mutual understanding. explore sensory, executive functioning, and emotional regulation needs, and consider systemic stigma around masking, burning, and identity related stressors. Um, and we also, some of the another pattern that I didn't put here that came up while I was talking about this is I also see a lot of folks, maybe around the misinterpretation of intent, but a lot of times we can have some really heavy emotional emphasis put on this misinterpretation of intent from both sides, from both the neurodivergent and the neurotypical person. When we misunderstand the intent, we can really tie some like heavy emotional feelings to what we thought we understood or what the person thought they understood. And that can significantly derail the relationship or derail like how they're interacting in the relationship. And that's something that becomes much easier to deal with when we make that explicit. But that's a very common relational pattern I see, especially in like neurodivergent versus neurotypical partnerships and couples. But I also sometimes see it in just like different flavors of neurodivergence or same flavor of neurodivergent, but like different, presentation. Just something to maybe keep in mind. And then substance use disorders. So common relational patterns, secrecy, distrust, emotional disconnection, conflict escalation or instability within the relationship, cycles of caretaking, enabling, monitoring, blame, or resentment, difficulties related to parenting, finances, intimacy, reliability, or emotional safety, shame, avoidance, or defensiveness surrounding substance use patterns, and just difficulty with like being honest about maybe what's going on when it comes to substance use, right? And the therapeutic considerations are assessing for safety concerns, withdrawal risk, and level of care. So can we need to be referring out when appropriate? Explore relational and emotional functions of substance use, avoid moralizing, shaming, or reducing the relationship entirely to substance use, support accountability, communication, emotional safety, and appropriate referral when needed. And again, like scope of practice, some states you can work with substance use disorders without additional credentials. Some states require that you have additional credentials. So you need to be checking in on your specific state around if this is something you can work with, or at least something that you can work with as the diagnoses, right? But even if you're not working with this as a diagnosis, substance use is likely to come up when you're working with couples and relationships and individuals, and we should be assessing for that and referring out as appropriate. And then something else that we want to consider when it comes to diagnoses, in general is again that like we're going to refer out as appropriate and that we're going to go back and make sure that when we're treating these things, we're treating them well within our scope of care. So go back and look at past lectures, go back and look at things. But if you find yourself lost in a situation, you can do consultation. If you find yourself lost in a situation, you can refer out. But we don't continue on when we don't know what to do, because that's outside of our scope of practice, right? So that's why consultation is so important. That's why supervision is so important, that we are diagnosing and we are treating within our scope of practice, even when what we're working with is relational therapy. Okay, so we ended on substance use disorders, and that's a very good transition to actually talking about substance use in partners therapy. So substance use in partners therapy is understood not only as an individual concern, but as a relational, systemic, contextual process may impact the couple and family system. That likely will impact the couple and family system, right? So systemic thinkers. Substance use and clinical competence. So why substance use matters in partners therapy. Substance use can impact trust, intimacy, communication, parenting, sexuality, and conflict within relationships. Partners and family members are often affected even when they are not the identified client. Substance use may function as coping, emotional regulation, avoidance, or self-medication. Relational distress may both contribute to and be impacted by substance use. Substance related concerns commonly emerge in couples and relational therapy. So even if that's not what you're treating, even if that's not why they say they're there, um, it's very common for them to come up. And it's very common to come up in ways you maybe didn't expect to see. Um, but like they may, we may be like decades in recovery and this may still be an issue. There may still be things that come up. There may still be old resentments. There may still be interactions with going to group meetings or things like that that are still going to be related to the substance use, right? And then therapists should consider the relational, cultural, and systemic context of substance use. Legal, ethical, and scope of practice considerations. So again, laws and credentialing requirements related to substance use treatment vary by state. Some states, for example, Colorado, requires additional credentials or certifications for substance use treatment. Therapists are responsible for understanding the laws and scope of practice in the states that they practice in. So you need to look that up and find out what that is for your state. Competence requires appropriate education, training, supervision, and consultation. Therapists should recognize when referral or collaboration with specialized providers is appropriate. Substance use concerns may involve additional safety, ethical, and level of care considerations. So we may need to be doing some like risk considerations around substance use. Substance use is not always the presenting problem. In fact, it rarely starts out as the presenting problem. Occasionally, very occasionally, but most of the time it's not. So clients may initially present with conflict, anxiety, trauma, parenting concerns, communication difficulties, rather than substance use. Substance use patterns may emerge really gradually during the assessment and relational work. One of the partners may not even know there's substance use in the picture, right? It may just come out very slowly. Therapists should be curious about the role of substance in coping, conflict, emotional regulation. Remember that shame, stigma, and cultural factors can impact disclosure and how you interact with those things. And substance use exists on a spectrum and may impact relationships even without a formal diagnosis. Assessment should prioritize curiosity, safety, and non-judgment rather than immediate confrontation. So looking at substance use with the partner therapy models we've been working with this semester, emotional focused therapy, EFT, substance use may be understood as connected to attachment injury, emotional disconnection, or regulation difficulties. Therapists focus on identifying the emotional and attachment related cycles surrounding substance use. Substance use may function as protection from vulnerability, shame, fear, or emotional overwhelm. The therapist helps partners increase emotional safety, vulnerability, and attachment responsiveness. And treatment focuses on de escalation, emotional engagement, and restructuring attachment interactions. The Gottman method. Substance use may contribute to conflict escalation, distrust, emotional disengagement, and negative interaction cycles. Therapists assess how substance use impacts friendship, communication, conflict management, and trust. Interventions may focus on reducing criticism, contempt, defensiveness, and stonewalling around substance-related conflict. Therapists support communication skills, emotional regulation, accountability, and repair attempts. An assessment of relapse, secrecy, betrayal, and trust rebuilding may be clinically important. The developmental model. Substance use may emerge during periods of developmental stress, differentiation struggles, or relational imbalances. Therapists explore how substance use impacts maturity, intimacy, flexibility, and relational functioning. The model emphasizes balancing connection with autonomy and self-development. Therapists support increased differentiation, emotional tolerance, and relational responsibility. And conflict around substance use may reflect deeper developmental and relational struggles. Imago relationship therapy. Substance use may activate earlier relational wounds, fears, shame, or unmet emotional needs within the relationship. Therapists explore how partners experience and assign meaning to substance-related behaviors. Structured dialogue may help reduce blame, defensiveness, and emotional escalation. Therapists encourage empathy, validation, and emotional understanding surrounding substance related conflict. And treatment focuses on transforming reactive cycles into more conscious relational interactions. Object relations therapy. Substance use may function as protection from painful emotions, attachment wounds, shame, or internal conflict. Therapists explore how earlier relational experiences shape present reactions to substance use and intimacy. Substance related conflict may involve projection, splitting, defensiveness, or abandonment fears. The therapist helps partners increase insight, reflective capacity, and emotional awareness. Treatment focuses on understanding emotional meaning beneath relational reactivity and substance use patterns. And integrative behavioral couple therapy, IBCT. Substance use may be conceptualized within recurring relational patterns, emotional sensitivities, and behavioral cycles. Therapists balance change-oriented interventions with emotional acceptance and contextual understanding. Interventions may focus on communication, behavior change, emotional acceptance, and tolerance building. Therapists help partners recognize patterns of polarization and mutual reactivity with substance use. And treatment emphasizes both practical behavioral change and emotional understanding within the relational system. So again, if these are our models, if these are the ones you lean towards, go back, watch those lectures, reach out for help interacting with these things. I'm more than happy to follow up. Harm reduction and the therapist stance. When it comes to substance use, harm reduction is a key concept. So harm reduction recognizes that clients may have different goals related to substance use. The abstinence is not the only framework through which substance use can be understood or addressed. The therapist should avoid moralizing, shaming, or escalating stigma surrounding substance use. The relational therapist should remain aware of cultural, systemic, and socioeconomic factors influencing substance use experiences. The treatment may focus on safety, stability, communication, emotional regulation, or relational functioning, even when substance use continues. And that curiosity, collaboration, transparency, and non-judgment are often more effective than confrontation or power struggles. Assessment and safety considerations. So we've talked a little bit this semester about risk assessments. So this is going to be another area of risk assessment. We want to assess for overdose risk, suicidality, IPV, child safety concerns, and impaired functioning. Especially if we have young children in the home, we want to make sure that, there's always somebody watching them and taking care of them. And that might mean we need to do a mandatory report. We need to consider possible withdrawal risk, the need for medical or higher levels of care. We need to refer out whenever we're outside of our scope of practice, because we are not physical health providers, we are mental health providers. We need to explore the frequency, context, function, relational impact of substance use. We need to assess how substance use affects trust, parenting, finances, intimacy, communication, and emotional safety. We need to consider trauma history, neurodivergence, chronic pain, and medical concerns that may intersect with substance use. And we need to remain aware of mandated reporting, documentation, and ethical responsibilities related to safety concerns. Some common therapist pitfalls with substance use and partners therapy include joining with one partner against the other, often joining with the partner that's not using substances against the partner that's using substances. Reducing all relational distress to substance use alone, minimizing safety risks or severity of use, moralizing, shaming, or escalating defensiveness, ignoring trauma, attachment, or systemic contributors to substance use, overlooking the impact of substance use on partners and family members, and working outside of scope of competence or level of care needs, especially if your state requires additional competencies. So, and then before we go to our final reflection, I also want to take a moment to address, especially around diagnoses and referring out, something we've talked about a lot this lecture, that when it comes to couples therapy and partners therapy, that information belongs to the partner system. So if you're referring out, if you're coordinating care and things like that, we really need to have that that signed off on a release of information from all units of either the partnership or the couple. Um, if you have not seen that person outside of the couple, then we really can't um, discuss our work with them outside of that context of the couple or the partnership. So while we can refer them out, we probably can't be doing coordination of care unless like everybody's involved, which means that we need to have a conversation. You need to have a conversation with that couple around like HIPAA and private health information, and also around what secrets look like. So if one of the partners comes to you about, well, I've got substance use issues and you keep secrets, which you may, but that might be a choice that you make for your own practice. You need to decide what that looks like. I don't know if you can hear, it's, I guess, close to 4th of July, and I can hear fireworks going out outside my window. Um, but if they come to you that, like, I've got substance use and stuff like that, coordination of care may look different. If you can't send information or coordinate with another care provider because you can't get the partner to sign off, right? Um, so you may be referring out and having to coordinate care through that partner, rather than you directly being in contact. And it is okay for you to make it a requirement when we have risk levels and we have at-risk levels, that you make it a requirement of continuing care with the couple, that in therapy they're going, and you can help them work towards it, but they're going to talk to their partner about their substance use so that we can get that ROI from both folks if both folks agree to it, or all folks agree to it, right? The same with some of these other like communication issues. I've certainly had scenarios, even though I tell people at the beginning of every, like when I go over HIPAA and stuff, I talk about that this information belongs to everybody. And I've done my practice has like consulted with attorneys about this to like check in on this. That this is relational information. So we need ROIs from all peoples involved to do any sort of care communication, care coordination and communication with additional providers. And I've still had folks who really didn't feel like that would apply to them, including saying like other therapists have done it differently, which fair, everybody makes their own assessment, but that's not it's not something I'm not willing to violate HIPAA just because other folks have. So we need to be very, very clear that when we're talking to folks around these diagnoses and things like that, the care coordination will require that you get releases of information from everybody involved in couples relational therapy. So moving forward with our final reflections, take a breath, get to the end. I want you to just take a second to think about how can therapists use diagnoses and address substance use without reducing clients to labels or pathology, and really consider what does pathology look like and mean to you, and where have you maybe used pathology without realizing it. So pause and take a second to think about that. And then, if you have any questions or any follow up, please feel free to reach out to me.